presentation, there will be a 10-minute question and answer session. So you would be able to interact with Prof Ntsekhe then. The program for today is we're going to start with a very brief Revive study update. That is going to be done by Prof Mpiko, who is the Revive Steering Committee Chairman. And that will be followed by an introduction to our speaker of the day, Prof Mpiko Ntsekhe. He's the head of the Division of Cardiology at the University of Cape Town, and he's going to be presenting on HIV-related cardiovascular disease in Africa. The recording of the webinar will be uploaded to the website, but you're also welcome to put your email address in the chat box and I can forward this to you. So I think we start by over to Prof Mpiko with the update.
Thanks very much, Elsa. So as Elsa said, this webinar and the webinar series is hosted by the Revive trial, and we invite a broad audience. And so at the beginning of each of the webinars, we just give an update on the Revive trial and also an introduction to what the trial is about. So the Revive trial is funded by the Gates Foundation and is co-led by the University of Cape Town and PHRI in Canada. And the trial is being done across multiple countries in Africa and asking the question among people with severe advanced HIV, so CD4 counts of less than 100, starting antiretroviral therapy or restarting antiretroviral therapy after an interruption, does 4 weeks of azithromycin prophylaxis daily at 250 milligrams a day, reduce mortality compared to placebo added to antiretroviral therapy and the current standard of care, which involves cotrimoxazole and TB preventive therapy and screening for cryptococcal disease. So we're really asking the question, does enhanced bacterial prophylaxis against bacterial infections in this vulnerable population with immunosuppression with azithromycin reduce mortality? And the trial is being done currently across 11 countries in Africa, and you can see them listed in green there. We have 2 countries that are planning to join the trial and are currently awaiting approvals. And across those countries, there are currently 57 trial sites active. And this is just an update on recruitment. So the target sample size is a total of 8,000 participants across those countries. And we've currently, as you can see on this table, had recruited up to yesterday 4,998 participants, and just received an email about an hour ago from the program office at PHRI that the 5,000th participant had been enrolled. So currently 5,000 of the 8,000 participants have been enrolled. And this makes it one of the largest trials ever done in HIV therapeutics to date. And just showing you the progress in terms of recruitment, the blue line, our targeted recruitment, and the purple line, recruitment to date. And you can see we're actually ahead of projections now, and hoping to complete the trial in the first quarter of 2027. The primary endpoint is at the 6-month time point. So hopefully in the second half of 2027, we have an answer to this question, which potentially could lead to an update of the WHO guidelines if we show that azithromycin is effective and safe. So with that, that's just a very brief update to say I'm really looking forward to Prof Ntsekhe's talk this afternoon and dealing with the critical aspect of the care of people with HIV living in Africa. So back to you, Elsa. Thanks very much.
Thank you, Prof. Then, yes, it is my absolute pleasure to introduce to you Prof Mpiko Ntsekhe. He is the Helen Burger Professor and Chair of Cardiology at the University of Cape Town and Head of the Division of Cardiology at Groote Schuur Hospital. Professor Ntsekhe is a highly respected clinician, researcher, and educator with extensive training both internationally and locally, including Brown University, Columbia University, and the University of Cape Town. He also serves as co-director of the South African MRC's unit on the intersection of infectious and non-communicable diseases. His research focuses on cardiovascular disease in sub-Saharan Africa, particularly the intersection between infectious diseases and heart disease, and how we can improve outcomes through impactful clinical research. He has received numerous national and international recognitions for his contributions, and we are truly privileged to welcome him today. So over to you, Prof Ntsekhe.
Oh, thanks, Elsa, for that very generous and lovely introduction. Let me start off by saying a big congratulations to the Revive team. I'm quite jealous looking at that recruitment rate. I think I'm going to have to make an appointment with Graham to get some tips and tricks on how to do that. We've got some RCTs of our own on the go, and I think we would definitely benefit from understanding how you are doing what you're doing. So congratulations and early congratulations. And then a big thank you for inviting me to speak to this audience on this topic, which I've been engaged with for some time. So I've titled it Perspectives on the Risk and Burden of HIV-Associated Atherosclerotic Cardiovascular Disease in Sub-Saharan Africa, Implications for Policy and Practice. So I'm going to be focusing my time together on that. And the main reason I chose to dive in and sort of limit my focus to that is some of you with a particular interest might have noticed that what's Friday, I think it was, the ACC-AHA, that's the American College of Cardiology and American Heart Association and affiliated organizations really released their 2026 update on guidelines for lipid management and dyslipidemia. And in the guideline, for the very first time, they recommended that ART-treated patients or people with HIV who are over 40 should be added as a high atherosclerotic cardiovascular disease risk category, making individuals eligible for primary prevention statin. So that's the first time from a cardiology point of view, at least in the US, that has happened. And this really supports the United States HIV clinicians, various HIV clinician society guidelines on the same issue, and those were updated in 2025. Okay, the main basis for the updates in those guidelines this year was this study, which I'm sure many of you are familiar with, and it looked at a statin that isn't in much use here in South Africa anyway. I don't know about elsewhere on the continent, called pitavastatin, looking at its ability to prevent cardiovascular disease in HIV infection. It was published in 2023 and presented at various major HIV meetings throughout the year 2023 and 2024. And as you can see from this results chart, it really made a big difference in the group as overall, preventing or reducing the, major adverse cardiac events and death by a good 21% over a 5-year period. So on the basis of this cumulative evidence, all these bodies have recommended primary prevention statin. Now, since this, there's been a lot of discussion and questions around what are the implications for this, and particularly with the new guideline for us in Sub-Saharan Africa. I think it is an ongoing area of discussion, sometimes disagreement, sometimes debate. So I thought it might be a good idea to review the topic again. So my presentation goals really is I'm going to look at the strength and limitations of both remote, i.e. historically remote, and recent data on HIV-associated atherosclerotic cardiovascular disease and its burden in Sub-Saharan Africa. And then, as I said, discuss potential implications on this issue for local policy and practice as it relates to primary prevention. And really what I'll be doing is providing a personal opinion on this. Now, again, I'm probably preaching to the converted here, but I think we all recognize that the burden of HIV and its complications is actually characterized very uniquely by geographic asymmetry, which you'll see what I mean in a second. And the focus of HIV-related research has also been characterized by geographic asymmetry. And understandably, it's driven by local burden of disease and local imperatives. For example, REVIVE is really a study that's going to be done here in sub-Saharan Africa, and LMICS with a similar problem. And it's unlikely to be done in Canada, where John is, or the US. So here's an example of that geographic asymmetry. This speaks to age-standardized global HIV incidence per 100,000 as of 2021. And you see from the color coding here that, as we know, there's about 8 to 10 countries in sub-Saharan Africa that carry the huge burden of disease. And then there are other geographic areas around the globe, but it's really concentrated with us here relative to other areas around the world. Similarly, if you look at research on TB and other opportunistic infections and its impact, REVIVE is a nice example of that. That type of research is very much concentrated here in sub-Saharan Africa and other LMICs, and this looks at research output on HIV-TB by African countries. And this is one area of research where we almost dominate the globe, but again, it's really a reflection of disease burden. On the other hand, if you look at cardiovascular disease, this is a publication from Global Heart from 2021, looking at publication rates around the globe by geography. And here you see that in terms of publication output, it's very much dominated by North America, Europe, Australia, with some of the countries in sub-Saharan Africa looking a little bit more blue than others. But I mean, the emphasis here is that the cardiovascular research is really taking place where the burden of disease is, and I'll expand on that a little bit given some of the data indicating LMIC burden. Now, as I hinted at earlier, if we look at corresponding causes of hospital admission among people living with HIV worldwide, this is a publication by Graham and company from some years ago, 2017 to be precise. What you see is really that hospitalization and mortality through the 2000s for people with HIV has still been dominated by AIDS-related morbidity and mortality. Again, this is probably why you guys are doing REVIVE. And the bulk of it is here in the WHO Afro zone. If you look relative to the US and North America, you see that there are actually major differences, sort of 28% versus 63%. If you look at the contribution of cardiovascular disease-related hospitalizations and mortality, that is a very different picture. Again, in the Afro regions, it's as low as 3% relative to between 9 and 12% if you look at Europe and North America. And again, this speaks to where all the cardiovascular disease research is happening and why. There has been some cardiovascular disease. In fact, we were involved in one of those, but again, I'm really just bringing this to highlight that it isn't one's typical atherosclerotic-based research project. Here we were looking at what is a burdensome problem in our space, which is TB pericarditis, testing whether immunotherapy added to standard anti-tuberculous treatment might make a difference in mortality and cardiac-related outcomes. Okay, but again, emphasizing that it's still infection as it relates to the heart. So with little non-tuberculous related HIV cardiovascular disease happening here in sub-Saharan Africa, there's been a major reliance on information and data and research output from Europe and North America to try and help us understand local disease dynamics, local cardiovascular disease dynamics. And I'm not sure that that's always been to our benefit in terms of understanding what's going on. And I hope to show some of that. So, I mean, what does this information from North America and Europe show? Again, this is a review from about 2017, and it really summarizes the big burden there, showing that compared to age and gender matched controls without HIV, that HIV increases the risk of atherosclerotic cardiac events. And there we're talking about myocardial infarction, atherosclerotic stroke, peripheral artery disease, and the population prevalence of atherosclerotic cardiovascular disease in people with HIV relative to those without is between 1.4 and 1.7 times. Okay, I think it's fair to say that there's a very solid underlying sort of mechanistic premise for why that might be, even in ART treated people. And the idea there is that although you might not be able to detect replicating HIV, we know that in lymphatic tissue and elsewhere, the virus continues to replicate. And this leads to sort of subclinical immune activation and inflammation, and release of cytokines and related factors that oxidize LDL, lead to morphological changes that make these particles a lot more atherogenic. That thrombogenesis is stimulated. This combines at vessel level in places like coronaries and cerebrovasculature, leading to acute myocardial infarction, ischemic heart failure, and in some instances, sudden cardiac death. Now, I should say that although this basic science sounds very plausible, that all of it has been essentially cross-sectional in nature as opposed to experimental in the design. And therefore, we need to understand that the inference that one can make from the types of studies that have been designed to look at this up until now are limited. Okay, but nonetheless, it is what we have. And over the years, given the growing data from North America and Europe around this burden, and given the absence of that kind of data from us, a number of us from Cape Town specifically in Zimbabwe have been tasked over the years with providing status updates in the form of reviews and systematic reviews on what's happening with the understanding of HIV cardiovascular disease across the continent. Okay, so I've highlighted two in particular here, one from Circulation, another from Nature Reviews as far back as 2009 and 2005. And really what we were able to garner from sort of anecdotal evidence, looking at case reports, case series, and finding out what people are experiencing across the continent is that, unsurprisingly, TB pericarditis was the big sort of opportunistic cardiac disease with major impact. HIV-associated pulmonary hypertension was something that there were hospitals were experiencing quite a bit. This is all a pre-ART era. HIV-associated cardiomyopathy. And then there's this very sort of unique entity of vascular disease involving the aorta and its branches, where aneurysms and fibro-inflammatory occlusive disease was being encountered in people living with HIV. And then there were these sporadic presentations of acute coronary syndromes around the country, around the continent, but they were few and far between. I've left out other random case reports. These were the sort of 4 or 5 dominant things. I've spoken a little bit about the limitations, one being it was before ART, the design was problematic with retrospective review of echo records, etc. And again, the capacity for inference and generalizability was relatively limited. I should say that the period after 2017-18 saw a significant shift in interest in research-related non-AIDS adverse events outside of North America and Europe. And this was very likely driven by 4 major factors. The one was indeed the growing evidence that in these geographies, as ART treated people survived longer and longer, cardiovascular disease, morbidity, and mortality increased. And there was I'll call it curiosity, interest as to what that might mean for sub-Saharan Africa as our antiretroviral programs were growing and becoming more successful. Is this something we were going to need to have to start thinking about and planning? Second of all, there was a major increase in NIH, NIAID, NHLBI, SAMRC, NRF, and other funding agencies, increase in research grant funding available for researchers to investigate and address non-AIDS related adverse events around the globe. I've highlighted cardiovascular disease, but cancer and liver disease were also quite prominent. And then, of course, the success of the ART program in sub-Saharan Africa, and I've linked that to issue number 1 and 2 already. But this shows nicely the share of people living with HIV who were receiving antiretroviral by about 2017. It really was one of the great triumphs of healthcare over the last decade, where we were able to get to an area of sort of antiretroviral therapy denialism to having over 75% of people living with HIV on treatment, and it's been improving ever since. But as I said before, you guys know a lot more about this than I do. And again, emphasizing that with prolonged survival in sub-Saharan Africa, the questions around the implications for prevention and treatment on non-AIDS related disease was becoming more and more prominent. The fourth reason why this became an issue was this publication by Shah and colleagues. It was a systematic review and meta-analysis looking at the global burden of atherosclerotic cardiovascular disease in people living with HIVs, published in Circulation. And when I last checked, it had over 2,000 citations. So people really have been citing it, and it's influenced a lot of trial design, further research, and quite frankly, some of its conclusions, as you will see, were quite alarming. So in addition to looking at publications from around the globe, what the investigators of this in the systematic review also did was study sort of epidemiological models using very fancy equations to try and estimate burden in parts of the globe where direct data was missing. And as you can see from the color coding there, what they concluded was actually that the greatest burden of atherosclerotic cardiovascular disease actually may lie in sub-Saharan Africa, where they felt that the population attributable fraction based on their modeling was as much as 15%, which is quite high. And on the basis of this modeling, they said the real high burden areas were Swaziland, Botswana, and Lesotho. Now, for those of you who are in the region, will recognize that for many inhabitants of those areas, the idea that there was a high atherosclerotic cardiovascular disease burden, acute MI, and atherosclerotic stroke was quite unnerving and out of keeping with what they were experiencing on the ground. And to be honest, there was a lot of question, again, discussion, debate, disagreement about the applicability and generalizability of all this data from North America and Europe and its to sub-Saharan Africa. Okay, so in this debate, of course, there was, one could argue, good reason to believe the data, to believe the research. And some of that was basically that, look, the quality of the research is really good. And, science is science. If there's a good premise for accelerated atherogenesis, why reinvent the wheel? If HIV, we can show by decent mechanistic studies, then I think, it's reasonable to believe the data. For example, once it was shown that diabetes accelerates atherosclerotic cardiovascular disease pathogenesis, was a major risk, almost equivalent to having had a myocardial infarction. It wasn't necessary for people to repeat the same studies around the globe for them to be believed. Now, one big difference there, of course, is that you only have to walk around any hospital to recognize that people with diabetes actually do get many of these complications that are described. Other types of evidence that were emerging to support it were a growing number of publications, such as the ones I've shown here, looking at cardiometabolic risk profile and risk burden in people with HIV, ART treated or otherwise. And almost all of them that were emerging suggested that there might be a higher burden of cardiometabolic risk factors in people with HIV. But again, detailed analysis of many of these suggested that some of them, methodology and design, weren't optimal to be able to draw major conclusions. Sizes were small, many were retrospective, many were not in the community, often didn't have appropriate controls, etc. And all of these things, of course, influence how one should interpret these things. Were there additional reasons to doubt? Yes, and some of them I've already alluded to. Clinicians on the ground were basically asking some basic questions like, where are all these people with HIV? Where are all the patients? It's widely accepted, particularly during epidemiological transition where preventative measures haven't quite kicked in. You don't have a high population on things like statins and aspirin, that about 60% of people with atherosclerotic cardiovascular disease actually present with acute myocardial infarction. Okay, if you look at the other spectrum of disease, heart failure is about 10 to 15%, angina about 20 to 30%, and sudden cardiac death difficult to ascertain because they say it's difficult to ascertain. But again, it was difficult to sustain the argument that doctors in sub-Saharan Africa are not able to recognize these acute myocardial infarctions because they don't have ECGs and it's not a condition that they're recognizing, which was the sort of explanation that was being provided. But doctors on the ground, like I said, were just asking, where are all these patients? And then, of course, most of you will be familiar with many autopsy studies from across the continent of people with HIV, some of whom died unexpectedly without a diagnosis, some with one or other disease, but needing autopsy across the continent, as I said, and a minority of these suggested that atherosclerotic cardiovascular disease was prominent. Most suggested that there was little evidence of it. And in fact, when there was cardiac involvement, it was usually unsuspected TB that had disseminated to the heart. Okay. Now, if I go back and sort of do a deep dive on that systematic review by Shah and colleagues that I said was cited over 2,000 times, and was one of the things that sparked a lot of this discussion. It was to make up the systematic review, they had reviewed 80 cohort studies from around the globe, most of them from Europe and the US, but there was a sizable amount from South America and elsewhere. There were 800 million people with HIV in these 80 cohorts. 800 million patient years, not 800 million people. That would be a little bit hard to achieve. And over the follow-up period in the cohort studies, there were 3,500 events. Now it's notable there were only 2 studies from sub-Saharan Africa, Tanzania and Ghana. And of those 3,500 events, less than 25 were from sub-Saharan Africa. None of them were myocardial infarction. All were strokes. And importantly, there were strokes or so-called strokes in ART-naive participants. And again, I think we all know that when people with advanced HIV and immunosuppression present with neurological insults, very often there's an alternative opportunistic infection or something else to explain it other than atherosclerotic cardiovascular disease stroke. So again, there was reason to sort of question the premise upon which they made their findings, even if it was with modeling. So in addition to this, there have been 2 recent, very well-designed studies, and they've allowed us to, in addition to some of the stuff that I've just spoken about, pause for reflection before we run ahead and alter our local guidelines, adjust budgets, and advise sort of more costly interventions for primary prevention. So the first one was this one, which was titled Epidemiology of Coronary Atherosclerosis Among People Living with HIV in Uganda. Okay, it was published in the Annals of Internal Medicine early last year by Sidner and colleagues. And the research question here was in a population of about 600 adults, all over 40, with and without ART treatment, will the 300 with HIV compared to age-matched controls without have more coronary artery disease prevalence and greater and more severe vulnerable plaques as identified and analyzed by CT angiography? Okay. So it was a community-based study, well-matched, well-conducted, it was prospective, looking at CT, which is a pretty robust measure of being able to analyze atherosclerotic plaque burden, morphology, and identify vulnerable plaque. The issue around vulnerable plaque was important because there was the possibility that if you didn't have much plaque burden, if the plaque that you do have is vulnerable and driven by sort of chronic inflammation, then it might explain risk of myocardial infarction. So you might have low plaque burden, but high vulnerable by the morphology of your plaques might make you more susceptible to acute myocardial infarction. And the hypothesis really was that atherosclerotic coronary disease in people with HIV versus those without is more common, is more severe, and there's more vulnerable plaque morphology on CT angiography. Okay, and what did they show? Surprise, surprise. There was actually no difference in any of the variables they looked at, but more importantly than the fact that there was no difference between those with and without, the actual numbers, the actual prevalence of disease was incredibly low. Okay, so comparable studies in the general population have been done throughout the world, and an equivalent population in the US and Canada and Europe would show numbers that are closer to 15 and 20%, as opposed to what we are looking at in this population. Okay. In fact, some of this shows even higher. So what they did is they looked at similar studies, US, Sweden, South Korea, Uganda. It's in green over here, and you can see that similar studies from elsewhere showed a lot more atherosclerotic coronary artery disease than was found in Uganda. Okay, so again, given my long-standing interest, I was asked to sort of provide a commentary on the study. I did that with actually the help of Graham, although he wasn't acknowledged as an author. And the conclusion really was the HIV-associated atherosclerotic CVD burden, or I should say coronary disease burden, based on this, varies quite considerably around the globe, and importantly, often mirrors what one finds in the general non-HIV population. And much of what was available suggested that the prevalence in sub-Saharan Africa actually remains quite low. I should add at this stage that one of the things that I think is often very difficult for all of us to think about and digest is that many epi studies sort of speak to age standardized burden or age standardized prevalence. And of course, what that usually does is so that rates can be compared across populations, they imagine a spectrum of age that they manipulate and then make all the countries have the same. So there's the same number of older people, and the distribution across the ages looks similar. And they said, if you all had the same distribution of age, what would your burden of disease or prevalence look like given what you have in the country? Now, of course, that's important for being able to compare, but what that sometimes does, sometimes that matches very closely with what actually you experience on the ground, but in many instances, and this is one of them, it is a little bit exaggerated from what is on the ground. So the Institute of Health Metrics in Washington State that runs a global burden of disease project also just releases raw numbers. And so, for example, if you look at atherosclerotic cardiovascular disease burden in sub-Saharan Africa, it is well below the rest of the continent. I actually thought I'd put in that slide to show that. But whereas the US, Canada and Europe run between 15 and 21%, sub-Saharan Africa runs under 10%. I think the big difference for us is case fatality rate and morbidity and mortality, because unfortunately, because of available health structure and often the sort of advanced intervention that one needs to treat people who do have events, and the fact that we don't have all of that available to us, if you get an event, then it's often fatal or very debilitating. So that skews often the morbidity, mortality data that we do have. But again, suggests that there's room for us to prevent getting up to that 15, 20% prevalence rates that's experienced elsewhere. I'm going to come back to the Reprieve study that I said at the beginning was a big catalyst to changing the guidelines, and just look at the about 1,000 or 1,200 patients that were enrolled in Reprieve from sub-Saharan Africa. So the research question there was they had about 7,800 ART-treated people with HIV, all over 40. They had applied a risk score that made their score actually low to intermediate. And they asked the question, will pitavastatin at 4 milligrams a day compared to placebo change or reduce the cumulative outcome of major adverse cardiac events and death over a period of 5 years. So this gives you an idea of all the countries that were involved. You can see that sub-Saharan Africa was well represented. There was 1 or 2 Reprieve sites here in Cape Town, and we contributed about globally as a continent 15% of the trial population. And here are the results as I showed them to you. If you look at MACE alone, then you can see that the hazard ratio was quite impressive. But even if you look at MACE and death as a cumulative outcome, the risk reduction was quite impressive. And it's understandable that guidelines in the global north have changed following this study. What is important, of course, is to look at the event rate, that MACE and mortality rate around all the geographical sites to see whether or not there were major differences. All right, so here is the data stratified by WHO region and high and low income. So Europe and the North America are represented here by the high income category, and then everybody else is over here. Sub-Saharan Africa, we are over here. And as I've already said that we recruited about 15% of the patient population. This shows some select demographics with regard to age and gender. I think it is noticeable in line with our demographic profile of HIV that we had many more women participants than high-income countries, where 79% were participants, were male. And smoking was not too different, but it was much more in high-income countries. And what you see in this population then is that the MACE rate per thousand, sorry, I don't know what's going on now. The MACE rate per 1,000 person years was 10.7 in high-income countries and only 1.8 in sub-Saharan Africa. And this is, like I said, over 1,000 patients followed over 5 years, very little loss to follow-up, very complete data. And the implications of this difference for number needed to prevent one major adverse cardiac event over 35 years, I've highlighted there in red. So in the US or Canada, you would need 35 to treat 35 patients over 5 years to prevent one major adverse cardiac event, whereas in sub-Saharan Africa, it's well over 200 with cost implications, adherence implications, and all manner of health infrastructure implications. So just to summarize and conclude, it looks like the cumulative evidence that's available for us to date is that the risk and burden of HIV-associated atherosclerotic cardiovascular disease in our environment is much lower than elsewhere, and at present would not, in my opinion, justify status as HIV of PWH as a major atherosclerotic cardiovascular disease risk condition. That the current WHO endorsed policy of prioritizing lifestyle behavior and related prevention measures with aggressive risk factor modification in individuals who require it should remain the strategy, while policy intervenes with regard to smoking, making neighborhoods safe for walking and exercising, targeting diet and horrible fat and etc. in the diet is a much more long-term plausible approach, not just for people with HIV, but for the population at large. I think it's fair to say the continent as a whole is undergoing what is a complicated epidemiological and demographic transition. I use that term because, whereas the traditional epidemiological transition was characterized by fading of infections and early infant mortality, here we have what are colliding epidemics, and we have to understand how all these things interact. But as I said earlier, I think under the current circumstances with available data, it would seem premature to recommend routine statins for all adults over 40 with people living with HIV and antiretrovirals. So I'll stop there. I hope I kept to the 45 minutes that you had given me, or 40 minutes. And I am happy to entertain any questions or comments if there are any. Thank you.
Thank you very much, Prof. I think we can give you another 2 hours to speak, and you'll be able to entertain us. So yeah, let's go to the floor, and anyone who's got a question, please just raise your hand.
Looks like John's hand's up. John, you're not allowed to ask any difficult questions.
Mpiko, thanks very much. Great to see you, and thanks for a super talk. I'm obviously not in Africa, and I feel as though I'm totally ignorant. It's 1 billion people in Africa, and so my question to you really is, with such a large number of people, with so many different countries, with differences in cardiovascular risk profiles, presumably, there must be heterogeneity in risk also in association with HIV. Are there high-risk countries? And anecdotally, I'm thinking here of, having spent just a few weeks in Sierra Leone and thinking anecdotally that the cardiovascular risk profile might be far different in Sierra Leone than in Uganda. So I wondered if you could comment a little bit more on that.
Absolutely, and I think so. This is really about routine blanket for everybody. Local, and that's a part of what we said in that editorial, is that this should spur all of us to get a better feel and understanding of what's happening in our local environments. Much of this was focused obviously around where the disease burden is greatest. Sierra Leone, as far as I'm aware, isn't one of the big 8, so to speak. But I should say that in terms of if you look at WHO STEPS data and you look at other measures of risk, hypertension still remains probably the biggest single risk factor across that belt. Sierra Leone, Nigeria, Ghana, in and around those countries. But I think to answer your question, heterogeneity is important, and in the same way that the entire continent shouldn't be brushed with one stroke in favor of statins, we shouldn't dismiss it against statins. I think that's a fair statement.
Thanks very much.
Graham, you've got your hand up.
Yeah, thanks so much, Mpiko. Great overview, and really enjoyed your reflections on some of the controversies. Just you picked up on the issue of the background risk of atherosclerotic vascular disease being low in Africa generally, and that explains, why we see differences in people with HIV. Just interested if you just looked into the future, what your thoughts are. So really asking you to speculate in 10, 20 years' time. And just in general, do you anticipate that there will be an increase in atherosclerotic vascular disease in Africa? And are there any, early signals, for instance, in the Heart of Soweto study, to suggest that that is starting to happen? And will it be diet that drives that, or what factors do you think are going to drive that in communities? Thanks.
Great. So the answer is yes. I think 20 to 25 years or 30 years from now, touch wood if we're still around, things will be very different. However, what I should say is that the change in age profile and the demographic profile and the population growth might be the biggest contributors to the burden. Okay. I don't think we will be the continent of youth forever. Our demographic profile will change over time. We will have many more people, hopefully that age, and as life expectancy grows, we'll have many more old people. And of course, wherever you're looking, drive burden. And then as population numbers. So, and that is true across the globe now. So if you look wherever you're looking, those two factors are some of the biggest drivers of growth. If you then add risk, okay, and the contribution of diet and all, diabetes and all these other cardiometabolic profiles that are going up, it's actually interesting because if you speak to public health and epi folks, what they suggest is that I think we always need to remember there's a huge opportunity given where actual prevalence numbers are now to implement some successful policy strategies. So, I mean, I can just speak for South Africa. I mean, all the smoking legislation, for example, if you look at modeling and what that might do with regard to risk mitigation is very big. So there's an opportunity really not to fall into the trap that has happened elsewhere. I think between diet and the obesity epidemic, that might change what happens. But I don't anticipate that over and above age and population growth, that the cardiometabolic risk profile will contribute as much as it has elsewhere. And I think there's a major opportunity for us to do something about it. So yeah, on the upside, that I'm positive. On the downside, if we don't do anything about it, then we are facing proper trouble.
Thanks.
I think we have time for one more question. Would there be any?
Elsa, I asked Kemi if she would just give a perspective from Nigeria. It'd be fascinating to hear.
Okay. Hi, Kemi.
Thanks, Kemi.
Hello, Prof. And hi, everyone. Thank you for a really enlightening lecture. It was really good to listen to that. So speaking from Nigeria, cardiovascular disease amongst our population is something that we haven't really studied as well. And I don't think we have a good grasp of what's going on exactly. And then another way that I kind of look at it is that in HIV, particularly in advanced HIV, we have advanced HIV is a disease of poverty. And to a large extent, HIV itself is a disease of poverty. And so that has an effect on some of the on the ability to seek care, on the ability to obtain care when you seek it, and it also takes away some of the risk as well, in terms of, if people who are lower down on their socioeconomic scale are likely to move a little bit more. They're likely to be more they might have a healthier diet, a less processed diet, and so on and so forth. So one wonders whether there's a bit of a canceling out effect, where the more affluent, who might put themselves at risk by maybe smoking and being more sedentary and so on and so forth, might also lose the benefits that the less affluent have, because they're physically more mobile, and because they might have a more natural diet and maybe a little more organic diet. So we don't, and again, because of a lack of access to universal health care, anything that's not in the national guidelines is really not going to get addressed as a whole. So we're not really able to, it's difficult to determine how bad the burden of disease is as concerns cardiovascular disease. And I think that's kind of where it's hard to say. It's hard to say. And one of the major questions I always have, because we have quite a little bit of renal disease in our patient population, is it safe to use abacavir? We understand that the HLA B5701 is not really a thing in the African population, but we put so many patients on it without ever testing, and you just wonder, is that safe from the cardiovascular standpoint? And we also do have a lot of out-of-hospital deaths, people reportedly kind of feeling well and then dying in their sleep. So it's hard to say. It's really hard to say, and I think it has been said today that it's just something that needs to be studied. We need just a little bit more insight than we have.
If I can respond to some of what you said. So Africa is actually the one region where there's a paradox between, so if you look at the social determinants of disease, you're absolutely right. Generally speaking, some of the things that you spoke about related to poverty, et cetera, have a huge impact on risk. Africa is the one geographical region where there's a paradox, where actually more poor, more rural folks tend not to eat. For their diets are, from an atherogenic perspective, tends not to be the McDonald's or whatever diets that more urban and wealthy people have access to. What the, again, epidemiologists tell us is that some of these behaviors, like access to the tobacco and being able to buy smoking things and the salty foods and the fatty foods, are actually the purview of the more wealthy in society. So there's this paradox where there isn't the same kind of linear relationship between the usual measures of social determinants of health and atherosclerotic cardiovascular disease burden. For most of the metrics that they look at, again, John's on the call. So PURE has been which is run by Salim Yusuf and that group, looking at these kind of issues from around the globe, has been very, very, very helpful in sort of trying to unpack many of these issues. I'm sure you know DK Oji and company very well.
Yes.
Their focus has really been on hypertension in Nigeria. But if you listen to them, that, again, it's about opportunity for making a huge difference in the high burden areas. So again, we need local data to make any conclusive recommendations, but that's how I would respond to that. With regard to the various drugs that you brought up, and some of the concerns that you raised. The one thing, again, depending on how much you believe in biological models of things, whether or not drug-induced dyslipidemia is as atherogenic as other mechanisms of getting dyslipidemia and altered lipid profile is something that was never quite resolved. And in a way, with the integration of new antiretrovirals and leaving the old ones that caused cardiometabolic disruption, we'll never really get appropriate answers to those kind of questions. So based on what's available, I must say I'm still very unsure, uncertain about what the role of antiretroviral drugs and their contribution to excess risk is. So I'll just sort of leave it like that. But again, speak to the fact that you guys, for areas where we are still using those drugs, as an opportunity perhaps to answer those kind of questions. So I'll leave it there for now. Thanks.
Thank you. I would also like to
start?
add real briefly that from a health systems perspective, HIV care is completely siloed. And so when people need any kind of cardiac care, they go outside of the HIV system, and we never really hear what happens with them, what was found, what is being done, what the intervention is. And so that's a wall that needs to be broken down to help us to get that data as well. Thank you.
Good point. I think that's true in many of our countries.
Thank you, Kemi. Graham has got a last comment.
Yeah, just to say thanks so much to Mpiko again for sharing your expertise. And then just, at the beginning of the webinar, I mentioned that the REVIVE trial had reached 5,000 participants out of the planned 8,000. And just, I see that many of the investigators from the sites are on the call, and just to really pay credit to the incredible work that people have been doing at the sites, in terms of recruitment, but also in terms of care of participants and attention to the data integrity. And really, it's a credit to the work that people at the sites and that the program officers have been doing. And just to acknowledge that and to express our gratitude towards all the hard work that's gone into that. Back to you, Alta.
Thank you, Graham. And thanks again, Prof Mpiko. This was really insightful. We appreciate your time, and we will make sure that we get you back. And then lastly, just to close off, our next webinar is on the 22nd of April, and it's going to be presented by Prof Wendy Spearman, and she's going to do a talk on HIV and hepatitis, and we will share that invitation with everyone soonest. So thank you for joining, and may you all have a good week further.
Thanks again for having me.
Thank you.
Alpha.
Thanks, Prof. Keep well. Bye.
Bye.